Hello, and thank you for joining us for this second session on using the OneHealth tool to budget for TB programs. These materials have been prepared by myself, Rachel Sanders from Avenir Health, and by Inez Garcia Baena from the WHO Global TB Program. As a reminder, there are a number of different sessions designed to prepare users to estimate the cost of their TB plan. The first was a general OneHealth tool overview. This session follows that general overview with more specificity around its utilization for TB. The next session covers some of the special features that are available to users of the OneHealth tool, and then there are sessions on the impact models. The content of this session 2 includes the learning objectives, followed by some discussion of configuration options, and discussion of the particularities of the OneHealth tool for TB intervention costing and program costing. After this session, we expect that users should understand how target populations, populations in need, and coverage are defined for TB services, know the special features that have been set up for TB program costing, and be able to find and utilize these elements in the software. There are a number of special adaptations for OneHealth Tool TB. The first is that interventions and program costs have been defined based on the NTB strategy and the WHO OneHealth TB module companion book. If you wish to download that companion book, the website for it is at the bottom of this screen. There are a number of different complementary features of the intervention and program costing. And the budget mapping includes default Global Fund TB interventions and OneHealth Tool programs that allow you to assign outputs to the WHO annual TB budget reporting categories. The TB costing component is also linked to the TB impact modules, including estimates and impact. There are two areas in which you need to think about your configuration in the OneHealth tool for TB planning. The first is around costing. Your first option there is sector-wide costing, which is what we discussed in the first session, where you would calculate drug and supply costs for each intervention and program area. But health system costs, including human resources and infrastructure, are calculated by the health system building block for the system as a whole. The second option within costing is what we would call disease-specific costing or vertical costing approach. You still calculate drug and supply costs for each intervention and program area, but you have the opportunity to calculate labor and visit costs by intervention instead of for the health system as a whole. And so this allows you to estimate the utilization of labor and resources for outpatient visits and inpatient days for TB. The second area where you need to make a decision is around impact. Which impact model will feed the populations and calculate the impact of your program. The first option is what we call time impact. It's a dynamical model. It's suitable for longer time frames and reflects policy shifts, but it does require a greater expertise in modeling and additional data. And so for that reason, if that's not available to you, we suggest the use of the time estimates model, which comes pre-populated with data provided by countries to the World Health Organization and estimates of the tuberculosis burden. It's appropriate for shorter time frames, 5 to 7 years maximum, and has a limited ability to reflect the impact of policy changes, but does provide a robust estimate of populations such as notifications, populations needing treatment, etc., that are needed for costing. This next slide focuses on areas where the planner for TB will follow a particular utilization of the OneHealth tool costing method. Just a reminder, when we calculate the number of services, we start with the target population, we multiply that by the population in need, by the intervention cover in each year, and by the distribution by delivery channels or level in order to get the number of services. We calculate the cost per TB intervention or service based on the treatment inputs for drugs and supplies. And if you've selected the disease-specific costing option, we also incorporate costs for personnel time and inpatient and outpatient visits. There's a little variability as you look at each type of intervention. For diagnostics, we start with notifications as our target population, and we use the population in need to reflect the number needing to test. So for example, for every person that you identify as a person with TB or who gets notified through microscopy, we use the starting population as the notifications, and then we multiply that by the number needing to test. So if you need to test 9 people for every person that you identify positive, or have an NNT of 9, then your PIN is 900. So 9 times 100%. For multi-test items such as smears, you can also incorporate the numbers of tests in the PIN. So that presumes that you're starting with time estimates where you generate a number of notifications, but you don't have an estimate of numbers of tests. That same pattern is followed by time impact, but there is an optional add-on called the diagnostic algorithm. If you are using the diagnostic algorithm, you have the option to generate numbers of tests as your target population, which is a selection in the drop-down menu, and then you would set the population in need and coverage to 100% to essentially equate the number of services to the numbers of tests. For the populations in need for treatment, you can set it to 100%. Everybody who's notified should be treated. Patient support, you can set to 100% if it's meant to be for everybody, or if you're doing eligibility by the poverty line, you could put in a percent living below poverty. And then for monitoring, we typically set the population in need equal to the number of tests per year times 100. Coverage has a few specific elements for TB, particularly for diagnosis. For diagnosis, we use coverage to represent the distribution of diagnostic options. So for example, if 50% of notifications through the passive case finding program are achieved using microscopy, then we would set the coverage for microscopy equal to 50%. And so because you're starting with notifications as your universe of people needing and getting the service, we really use coverage as a distribution effort for diagnosis and not as a coverage as it's specifically perceived as number reached divided by total burden. Treatment coverage follows the more typical pattern and reflects linkage to care of notified cases. And monitoring coverage reflects essentially coverage of monitoring programs amongst those on treatment. For TB intervention costing, there's a cost per service, which is assembled using the standard OneHealth Tool ingredients approach. Default treatment inputs are supplied based on the WHO OHT TB module companion book and include drug regimens per treatment type, other consumables for diagnosis, unit costs, personnel time, and outpatient visits and inpatient days. We do encourage users to adapt these to fit with country norms or with other representative data. Program costing also has some special elements for TB. You can see on the left the standard list of program cost categories that you'll see in every health area, but there are some additional ones for TB, including collaborative TB HIV activities, high-risk groups, infection control, childhood TB, apart from the consumables for treatment and identification, PPM, ISTC, community involvement, partnership initiatives, and TB research. One other point to make is that the lab costs for TB can also be calculated linked to the volume of tests so that you can ensure a syncing up of those assumptions. I am going to move to a software demonstration now, including the configuration editors where you need to select your impact models and costing approach, how you would look at changes in the TB diagnosis mix using coverage, and look at costing prevention, testing, and treatment, since this is a newer element of the tool. And then finally, we'll look at program costing, including specifically how lab costs for TB can be calculated linked to the volume of tests. So I'm starting from an open file here. This should be a familiar screen. If you watched our first video on using the OneHealth tool, you can see that I've selected the TB program area, and the ribbon across the top shows the different elements for TB costing. I am going to start with configuration, and you can go to the projection options tab where you have the option to do disease-specific costing. If you want to take that option, you should check the box for cost, labor, and visits by disease. And if you do that, make sure that you fill out salaries and time utilization in human resources, as well as the editor, which will be added to allow entry of costs of inpatient days and outpatient visits. If you don't fill out time utilization in particular, you will start to get errors as you run your results. The other point that I want to call your attention to is the section of configuration labeled TB. By default, the OneHealth tool assumes that you will be using time estimates to feed the target populations. If you are selecting a different approach, you should specify that approach here. If you're using the user-entered target populations from time, you should check the first box. If you're using time impact, check the second box. And finally, if you have selected the diagnostic algorithm tool from within time impact, then you should check the box to use numbers of diagnostic tests from that tool. For this purpose today, I am using a standard time estimates file from a sample country, and so I do not select any of these options. Once I've done that, you'll see that when you select target population, you'll see the tool calculating, and it brings up all the target populations that have been pulled in for each intervention from the impact model. So for example, number of new pulmonary bacteriologically confirmed adults for a diagnosis with microscopy as an option of the target population. Reminder that you can use your drop-down menu to select which you want to use if there's any changes. The population in need, again, is used to prescribe the number needing to test for diagnosis and the percent who should get different options in for the other services, such as treatment and prevention. Your coverage editor is again used for diagnosis to define the mix of interventions. So in the example here, I am specifying that at the beginning of the time period of interest, 90% of people found through the passive case finding program are found with microscopy. However, if we were in a situation where we were ramping up expert and we expected microscopy to diminish as a consequence to about 50% of the program, then I could put that transition over time. So for example, here, you can see that I am setting up a situation in which we start off with 90% distributed to microscopy and 10% to expert, but I want to ramp up expert now to about 50% so that all of my passive case finding is done through one of those two options. You can have a situation where there's another screening mechanism in place. You can exceed 100%. For example, if some proportion of the population also gets screening with x-rays, nothing is going to stop you from putting in the additional items, but you do want to consider your diagnostic algorithm in setting up that structure. So again, we want to distribute all our case finding across the different case finding options, the different diagnostic options. I've set this up for HIV negative adults. You also have the option to specify for each of your different special populations or unique populations, such as children, HIV positive, etc. Or if your program is essentially functioning as one kind of consolidated case finding program with no special features, you can just run everybody through the first type, the passive case finding program. Again, I want to remind you that the treatment elements represent linkage to care. So you've got notified cases as your target population, and then those linked into care should be your coverage. So if 85% of the group for first-line treatment is linked into care the first year, but you want to increase that to 95% by the final year, you can make that specification in the coverage editor. So once you reviewed your target population, your population in need, and your coverage, you should transfer your coverage to the impact modules. Wait for that success message, and then you can look at your results. So for example, I want to look at the drug and supply costs for my different TB interventions. And you can see that in the screen here. So this is going to reflect your selections of the different drug and supply costs. It also takes the treatment inputs into account. So everything that you've entered to define the cost per person reached is summed up to give you your cost per person or your unit cost, which is then multiplied by the number of services to give the drug and supply costs. So I want to take a few more minutes to talk about one additional element, which is the latent TB prevention and testing program. So this is a relatively new area for the tool. It's been built out a lot for users who are accustomed to what they saw in 2020 or earlier. So I'd encourage you to explore it a bit. And there's three main parts. The first has latent and active TB evaluation. So this is screening for the different groups. The second is testing, so actual testing. And then finally is the provision of preventive therapy, or TPT, to different groups. So you will want to start by looking at evaluation. We consider evaluation as the entry point to the program, and if a person has not been evaluated, then they will not then proceed automatically to testing or to treatment. And so you will want to include the coverage of your evaluation program, since that's the entry point, if you do include TPT or LTBI testing. Once you've set up the proportion of the different groups, household contacts, high-risk groups, and ART patients that are screened, you can proceed to look at testing. So if you do presumptive treatment, for example, for household contacts and you don't test them, you can just leave the testing at 0 and put TPT for household contacts at 100%. Conversely, if you do testing before treatment, for example, for adult household contacts, then you should put in the treatment coverage, or sorry, the testing coverage for that group. And you will want to hit transfer coverage to impact models if you make any changes here. If you want to get a better look at how this is modeled in time estimates, you can uncheck this box, or if you want to adapt it there, you can uncheck this box and go into the detailed time estimates editor. So once you've established the screening, the testing, and the TPT program, then you'll start to see the estimates of those costs incorporated into your program, and you can ensure that they're properly reflected. The last item that I want to show the group today is the special features of program costing. So you can see that down at the bottom of the screen, you'll have a number of different TB specific editors. So if you click on those, you'll be taken to a set of costing templates where you can put in different elements. So this is infection control. You can put in information about all the infection control options. And then if you look under establishment of new labs, if you double click on either 5.2 or 5.3, it'll take you to editors which calculate the number of tests that are needed each year, and then the associated number of facilities that are required to meet that need. So you should make sure that you review the information that's included here. So for example, the cost per facility, the number of tests that facility can manage, and then the baseline number of facilities. Once that is set up, then the tool will calculate how many additional labs you need. And then it will calculate that quantity through to give you a cost for establishment of new labs. So I think that covers everything that we're hoping to cover today. Thank you very much for your kind attention, and please be in touch if you have any comments or questions.